Welcome to the Catalyst Podcast, brought to you by Chestnut Health Systems. I'm your host, Charles Epstein. Today, I'm joined by Guida, founder of Guide Consulting Services, a 25-year-old consulting practice that helps corporate, government, and nonprofit clients navigate Washington policy processes to achieve measurable goals. This is Al's second time on the pod. Some months back, he joined me to discuss the Medicaid-related provisions in the so-called Big Beautiful Bill. Today, we discuss the Residential Recovery for Seniors Act, a bipartisan bill introduced by Democratic Representative Lauren Underwood, a registered nurse from Illinois, and Republican co-sponsors Carol Miller of West Virginia and David Valadao to expand Medicare Part A to cover residential substance use disorder treatment. Al, welcome. Thanks for joining me today.
Charles, I appreciate you having me on. I feel like a returning champion here. So thanks for having me on this afternoon.
Oh, yeah. Well, as I said, when I had you on to talk about the Big Beautiful Bill, you were just the guy to walk us through that. And you are just the guy to walk us through this. I was kidding in the lead up to this that, we're always talking when there's absolutely nothing happening in D.C. And you said, actually, quite the contrary. The last, 12, 16 months have been particularly active?
Oh, my God, yeah. It's been a whirlwind of activity, specifically on the mental health and addiction treatment front, both positive and negative. And obviously, we'll get into that, perhaps, Charles, later in this podcast.
Indeed. Excellent. So, I do want to talk about this Residential Recovery for Seniors Act. So if you would just start out and outline the key provisions. I know there are several.
There are. So we should just back way up, Charles. So now this is data from the Office of the Inspector General, the HHS Office of the Inspector General. The OIG is the fraud-fighting arm of the Department of Health and Human Services. And so when they examine the Medicare program and the Part D prescription drug program, now I suspect that they were looking at this because there might have been, and probably is, diversion of prescription drug opioids in that program. And the Part D program is the prescription drug program, Charles, for seniors that was created back in 2003. So what the latest OIG report finds, and this is from 2003, is that 50,000 Medicare recipients OD'd in 2023. And 750,000 Part D recipients, Medicare recipients, received Narcan, the overdose reversal drug, in 2023. So, Charles, I will tell you that the hardest thing about moving this legislation and talking to congressional staff about it is that when you go up to Capitol Hill and talk to congressional staff about it, the image they have in their mind is it's the Grant Wood painting. It's called American Gothic.
Right.
And I think, so that's what they have in their mind. It's the husband and wife. This is a 1930s painting, and the husband's got a pitchfork, and they're standing in front of the barn, right?
Mm-hmm.
So that's the image they have in their mind. It's of their grandparents. That's what they have in their mind. The modern generation of seniors is not that image. And specifically what we battle with when we talk about this legislation is that the opioid crisis is restricted to non-elderly adults. And that's not the case. So that the opioid crisis has spilled into the senior population, and that shocking data that I just discussed with you and our podcast audience is one of the reasons why we were able to get this legislation introduced with such a bipartisan support. What the legislation does essentially is two things. It defines residential treatment centers in federal health law. It makes those centers eligible for Medicare reimbursement, and only for the purpose of providing 3 levels of care as defined by the American Society of Addiction Medicine. That's 3.1, 3.5, and 3.7, which, Charles, are basically sort of ascending levels of residential treatment that are provided to individuals with substance use disorder. 3.1 being sort of the lowest level of residential treatment that can be provided. That's basically detox, up to 3.7, which is basically intensive medical management that's provided by a nurse, often overseen by a psychiatrist. So that's what the legislation does. It defines residential treatment providers in Medicare law. It makes those facilities eligible for Medicare reimbursement, but only for the provision of those 3 levels of care as defined by the American Society of Addiction Medicine.
Just because it's quote unquote bipartisan, which is to say you have at least one Democrat, 2 Republicans who are signing on to this, doesn't necessarily mean that it's going to ultimately have sufficient bipartisan support to pass. So where realistically is it? And what's its likelihood of passing?
So I gotta say that so now you described who two of the Republicans were. We have more Republicans. So on this bill, now, Charles, I don't want to give away my age. I've been a Washington lobbyist for a very, very long time, many decades. This is likely the first bill in a multi-decade career where I've got more Republicans than Democrats on a bill that spends money in the Medicare space in mental health and addiction treatment. So in addition to Representative Valadao, and in addition to Carol Miller from West Virginia, Representative Darren LaHood, who's a Republican on the Ways and Means Committee from Illinois, is also on this legislation, as well as Representative Mike Bost, who's the chairman of the Veterans Affairs Committee, also on this bill, is a Republican. So we have more Republicans than Democrats on this bill. And so that's, whoa, baby. I mean, I'm not a spiritual man, but that is almost a biblical miracle as it relates to this legislation. So to answer your question, the concern will be spending, and
Right.
that will be the primary obstacle here. So let's just back up a little bit. What is the cabal? Who are the co-conspirators behind this legislation? So they include Chestnut, the Illinois Association for Behavioral Health, the National Council for Mental Well-Being. They are the trade association for the community mental health centers and the certified community behavioral health clinics in the United States. The American Society of Addiction Medicine, representing the broadest number of prescribers for medication-assisted treatment in the United States, and the Legal Action Center. So these are the base coalition that's behind the legislation. So they financed a study from something called RTI, which is an actuarial firm that has a lot of experience, Charles, specifically in the mental health and addiction treatment space. The RTI actuarial study says that the Underwood legislation costs the federal government a bit more than $300 million a year, which to Republicans is a lot of money, I have to say. Now, we are credited in that actuarial study with a lot of offsets, because what they assume is that if you expand this, because of that huge number that I was describing, that huge number of of seniors that have either OD'd or gotten Narcan. They need residential treatment. Some number of those individuals likely benefit from residential treatment. They'll get residential treatment. Where do they go, Charles? They go to the emergency room. And an episode of a single day in an emergency room, a single episode of emergency care starts at $1,500. And then from there, if they need to stay in a psychiatric hospital or other, intensive residential stay, that begins at about $5,000 a day. So we get credit in the RTI study for offsets. If we avoid a stay in an ER, if we avoid a stay in a psychiatric hospital, if we avoid a stay in an acute care hospital, we're saving the federal government and the Medicare program a ton of money. So that's what the RTI study says. This costs $300 a year. And that will be the principal political challenge that we have in moving this legislation. I have some hope in that we have a lot of Republicans on this bill, Charles.
Yeah, no, it's kind of interesting because, not to make this a partisan argument, not every piece of legislation is created equally. In other words, you can do an ROI on one, an ROI on the other, and ultimately you also have to deal with, the cultural wins or obviously cultural hot button issues. And, when you have something like Medicaid or Medicare, they're automatically, to an extent, polarizing. And if you're a Republican, I think you always have to bear that in mind. It's not always just a cost benefit analysis, it's a political analysis, particularly if it's about an issue that may transcend dollars and cents and maybe a culture war kind of thing. So,
I really agree with that. And then, Charles, just two things. Okay, so look, I just want to put my cards on the table, right? So I have been a lobbyist in the mental health and addiction space for 3 decades. And when I started this in the early 1990s, a mental health and addiction treatment was not a bipartisan issue. And apparently in certain circles, it still codes liberal, but it's much more bipartisan than it was back in those days. And then I want members of this audience listening to this podcast to look up the image of American Gothic, Grant Wood's painting. I want you to look it up on the internet, okay? Because what we're talking about is connecting substance use to that image. That's why we've got more Republicans than Democrats on this bill, because it is a seniors healthcare issue, okay? So that's what gives me hope that that seniors are favored as a patient population in the Congress. And that's what gives me hope that we can get some legs around this thing because it's seniors and dual eligibles, really a less favored patient population. But it's seniors where we can get some traction around the substance use impact, particularly alcoholism, but also opioid use disorder in that patient population, assuming we can get over this idea that seniors don't get opioid use disorder. And I'm hoping that with further education, we can get some legs around this if we can do more education on Capitol Hill.
right. So just to put a fine point on the Grant Woods analogy here, American Gothic, you have what really is a quintessential couple from the Midwest, which, when you hear the real America or Americana, it sort of incarnates all of those characteristics or virtues, if you will. Are you saying that people are generally predisposed to embrace this because that's the image they have of seniors?
Yes.
Okay. Okay.
That's precisely the case. And then when you go up on Capitol Hill to talk about the bill, the first thing you have to say is the modern senior population is not that image. It's not your grandparents. Modern, the new generation of seniors, that are 65 and older bring the 60s with them into the Medicare program. That generation of seniors used drugs when they were kids. They continue that behavior in many cases into Medicare, and in many cases they misuse prescription drugs, and they still engage in illicit substance use disorder, probably engaged to a larger degree than their prior generations with alcohol use disorder, and therefore they need residential treatment because they need this intensive level of 24/7 services. So you begin with
I see.
that education
Right.
before you get into what is a residential treatment stay, what's an ASAM level of care, are these services provided,
Right.
and how is it financed?
Right. Not to belabor it, but the Grant Wood American Gothic is sort of that's the recognizable thing, and then you juxtapose it with the reality of today's senior and what they're dealing with, et cetera, et cetera. That's sort of the other side of it. But you already sort
Exactly
of
right.
draw people in because there's something identifiable about it. But oh, by the way, here's what you don't know.
That's exactly right.
Yeah,
Exactly right.
yeah. No, it's a really interesting way of going about it. I wonder, if passed, and I don't know if this is sort of beyond your pay grade because I'm really now talking about implementation, but I wonder if all of a sudden these funds become available for Medicare reimbursement. Will there be enough support? Will there be enough services? Is the infrastructure there? Are there enough people to deal with the influx?
So the podcast audience cannot see me smiling because, so Charles, as you can imagine, there's a dispute regarding this matter. So, Charles, there are thousands of residential treatment centers in the United States. Okay. So, the idea behind specifying the American Society of Addiction Medicine, the ASAM levels of care in the bill, is to shrink that universe of available residential treatment centers that could qualify to participate in the program. And the goal is to get back to one of the questions you asked me earlier on, which is to then shrink the Congressional Budget Office, CBO, as they say here in Washington, scoring for the legislation so that we can generate more congressional support. Okay. So the dispute is the following. If you Oh my God. If you talk to our friends in the insurance and the health plan community, all of those residential treatment centers, all of them abide by ASAM levels of care. So we save nothing, we shrink nothing. That's what they say. All right. Now, I don't happen to agree with that. Why don't I happen to agree with that? Because those ASAM levels of care require these qualifying centers to provide at least two forms of medication assisted treatment. So in this case, that would be Vivitrol. It's an injectable agonist. Basically, what that means is you have to be clean from this product for 30 days. If you get this injection, you can take an opioid, but you don't get high. They would have to have buprenorphine, which is another form of medication-assisted treatment that it's not an agonist, but it manages your cravings if you have opioid use disorder, and then you would also have to have medications for alcohol use disorder. Okay, you would be required to get Medicare reimbursement under this bill to both have these medications on site and then prescribe them to patients while they are receiving 24/7 care at your facility. Okay. That's what the legislation says. the vast majority of residential treatment centers in the United States don't have this capability. So, notwithstanding the input of our health insurance plan brothers and sisters, in fact, this would reduce the number of centers available that could meet these standards. And here's the thing: because of this discussion, Charles, of fraud and abuse here in the certainly in the Medicaid program, and specifically in the mental health and addiction treatment space in Medicare, we're constantly faced with these allegations. To my mind, it's better to say that if we have new mental health and addiction treatment benefits in Medicare, they have to be of high quality. They have to be pristine. They have to not be subject to fraud and abuse allegations. And then if we launch the program and it's successful, we can demonstrate quality, we can demonstrate clinical benefit for seniors with substance use disorders and opioid use disorders, then we can expand the program, and then we can improve the quality of residential treatment in the United States. And then that will, over time, increase the number of residential providers that meet these standards. So to my mind, last thing on this, Charles, in mental health, there is no harm in incremental change. There's no vice in incremental change. There are very few home runs in this business. So incremental change over time, incremental implementation over time is a successful strategy. That's what my 30 to 35 years in this business has shown. If we get this legislation passed and as a slow rolling implementation over time, I suspect that we benefit and that seniors with these conditions benefit over the long run. Does that make sense?
It does. Actually, I have a new slogan for you. Incrementalism is no vice. Of course, if you
Yes.
can live with the Barry Goldwater echo.
Yes. Yeah, pardon me for that.
Actually, that's a double. That may actually have two levels. But wasn't that, a not an echo, a voice, or wasn't that
Yes,
also a
yes,
Goldwater
yes. That was
slogan? I
also
think I have it
that was
close.
it. The American people don't want they don't want an echo. I can't remember the full phrase now, but you and I are showing our age, Charles.
But I think that was Goldwater, right?
Yes, it was also Goldwater. Yes,
Yes, yes. And for the record, a little bit, probably a little before both of our time, but we can
yes,
still be historical about it.
yes, we did.
So, are there any other names attached to this who expressed their support that would surprise people apart from Lode?
So right now we're trying to get the bill introduced in the Senate. Senator Welsh from Vermont is our lead Democrat, and now we're seeking Republican support to introduce the legislation in the Senate.
Any friends
Yeah,
there?
I'm trained not to say names that aren't on the bill already, but Senator McCormick from Pennsylvania is someone that we're hoping will see the value of getting onto this legislation in the Senate to give us bipartisan support for the very reasons that we've described here. Charles, Pennsylvania is the oldest state in America. In terms of average age of state residents, Pennsylvania is the oldest state in America. It has a terrible substance use problem. And so seniors in Pennsylvania would be particularly advantaged if Senator McCormick were to get on this legislation, were to join Senator Welsh in introducing this bill, and if we were able to attract his support, why this would be a significant achievement, a political achievement, as we move into the end stages of the 119th Congress.
Sounds like this ought, at least in theory, garner some Republican support, and we know that this is a real problem. So, are you doing anything? Or well, I should say, what exactly are you doing to raise awareness? Assuming there's some concerted efforts to do that.
Well, we are focusing our efforts now on Pennsylvania, obviously, and well, we've also reached out to Senator Collins in Maine again for the same reason, because of the average age of their state residents, and yeah, I won't go into detail here. It's slower going there. I mean, the senator's in a very competitive race in Maine, and yeah, I suspect she's more careful about what bill she gets on. But again, Charles, I have a hard time. This is a popular bill, and as demonstrated in the House, and I think that Senator Collins would be advantaged by being a co-sponsor with Senator Welch of this legislation in the Senate. If anybody's from Maine listening on this podcast, please contact Senator Collins's office to tell her to get on this bill. So that's just my own feeling on the matter.
I think, yeah, she is in a tough race, and everything is weighed within an inch of its life. So
That
it's almost like right now, it's best for almost to do nothing.
I'm afraid that's the counsel she may be receiving.
Yeah. Anyway, yeah, I wish you great success with this. And before I let you go, what else are you working on? Any big legislation barreling down the pike?
So, Charles, it's not legislation, it's regulation. So the just connecting back to our first podcast, the One Big Beautiful Bill Act is now law. And so what's barreling down the pike today is, as this podcast is being recorded on Friday, September 17th. On January 1st, 2027, the work requirements of that legislation, of the OBBA as it's known, will go live in 40 states that have expanded the Medicaid program. Now, I have looked at those regulations. I've read them, all 400 and so pages of them, because I've had to generate regulatory comments for clients. And the huge paperwork burden, Charles, that will be placed on mental health and addiction providers and patients with mental health and addiction disorders. My word, it will be enormous. And I think that the concern is that we will lose potentially millions of people with these conditions, will lose their Medicaid coverage. And then that will impact the financial health of mental health and addiction providers in the United States, including Chestnut. And so I think that that's a real pressing concern is how these providers are going to survive the implementation of these regulations, and how the patients that get their services through these providers will receive those services, and how they're going to hang on to their Medicaid coverage. So that's kind of like how do I say this? Charles, is sort of the sword of Damocles that's hanging over our field and really the entire Medicaid program at this point are these regulations. It's they've thrown sort of this enormous bureaucracy. Ironically enough, for a party that has fought the the bureaucracy, that these regulations throw this enormous bureaucracy at these patients, that I don't know how they're going to navigate all of this paperwork in order just to hang on to their health insurance. It's going to be quite a battle, really will. Beginning,
And
I
the
just
thing is that it's by design.
oh yeah, oh yeah, by design, by design. It's diabolic.
Yeah, I
Use the words,
mean,
it's diabolic.
I think typically bureaucracy just grows out of wanting to implement something. It just sort of an adverse consequence of that, and it just takes on a life of its own. And by virtue of inertia, it grows and grows and gets bigger. Whereas here, this is clearly a poison pill.
Yeah, it is designed to cost people their health insurance. And then I don't know, in the age of AI and IT, I guess there's some way to try to counter the sheer weight of these regulations. I guess the concern when you read the regulations, and I have with fairly closely, the folks that drafted them don't understand who the patient population is. I mean, individuals with mental illnesses and individuals with substance use disorder, one of the things that come along with these conditions is cognitive impairments. These conditions impact every aspect of cognition, executive decision making, memory, speech, and the idea that these patients are going to, every 6 months in certain cases, are going to have to requalify for their Medicaid coverage, or that they're going to have to specify that they have a disabling mental illness or a substance use disorder or an intellectual and developmental disability so that they can meet an exclusion category so that they can hang on to their Medicaid coverage. It's otherworldly. It's the folks that wrote these regulations, Charles, in what Ronald Reagan used to call the puzzle palaces here in Washington. They have no idea what it's like to be a Medicaid recipient, what it's like to battle for your rent money, much less to hang on to your health insurance every day. And these regulations are designed to bury you in paperwork. That's exactly what their intended effect is.
And this is coming January 2027.
January 1st, 2027. Happy New Year.
Happy New Year. Gee whiz. Well, I was hoping to end this conversation on an upbeat note. Is there anything upbeat you care to share with me, Al? Even on the personal front, anything positive going on in your life?
Note.
Yeah, we want to leave feeling good.
Charles, I found love late in life. I have a 17-year-old daughter. She got her driver's license 4 months ago. She hasn't hit anything yet. So that's a positive, right?
Excellent. Sort of, in the same vein, sometimes the best trades are the ones you don't make. That's excellent. Congratulations.
Absolutely. And I'm a Knicks fan, so come on.
You are a Knicks fan.
Oh yeah, absolutely, man. I'm a Knicks fan, so man, I would just
from like back in the day, or is this sort of a newfound?
Yes, no, I'm actually from New Haven, Connecticut, so about 90 miles outside of the Big Apple on Metro North. So I used to listen to Marv Albert calling the Knicks games back in the day. So after 53 years in the desert.
Yes.
After wandering from Egypt.
How thrilling and how great is this team?
Oh my God, it's unbelievable.
Do you love this team?
Oh my God. And you know what? Jalen Brunson is not 6'2". This guy is not 6'2". I think he's 6'1". And the idea that this guy beat the tallest player in the NBA, that's unbelievable. Right. That's also a biblical miracle.
Al, appreciate it again coming on and walking us through a rather complex but very important issue that can have great impact, particularly among seniors grappling with these issues.
Charles, I really enjoyed it. Thank you for the opportunity, man.
Thank you. Today, I spoke with Guida, founder of Guide Consulting Services, a 25-year-old consulting practice that helps corporate, government, and nonprofit clients navigate Washington policy processes to achieve measurable goals. This is Charles Epstein for the Catalyst Podcast, brought to you by Chestnut Health Systems. For more, go to www.chestnut.org. Thanks for listening.